Imaging in hyperparathyroidism in a minute. Hyperparathyroidism can be primary, secondary or tertiary. Primary, most often it is due to a single parathyroid adenoma which causes increased parathyroid hormone secretion. So imaging can be either of twofold: imaging of the parathyroid glands to detect a parathyroid adenoma, and the skeletal and extra osseous manifestations to look for features of parathyroid hormone action. Localization imaging is to detect a parathyroid adenoma. Most commonly used is USG, which is non-invasive and less expensive. Localized hypoechoic oval lesion with increased vascularity is seen in relation to the lower part of the thyroid gland. And the scintigraphy or technetium-99 system may be scanning. This is the most accurate method for a preoperative localization of parathyroid adenoma. In cases of resurgery or in ectopic parathyroid adenoma, you can go for a 4D CT, 3D CT in association with a pre-contrast and post-contrast study of the neck, which gives both anatomical and functional information about a parathyroid adenoma. Going to the osseous and extraosseous manifestations, skeletal manifestations, X-ray shows subperiosteal bone resorption, which is a hallmark finding most common in the radial aspect of the second and third middle phalanges. Other findings are cortical tunneling, diffuse osteopenia, osteosclerosis and secondary hyperparathyroidism, which can give the name signs like salt and pepper skull, rugose jersey spine. Brown tumor is a expansile lytic multiloculated lesion seen in association with hyperparathyroidism. This is an area of increased osteoclastic activity and area of fibrous tissue and hemorrhage. This is not a neoplasm in itself. Other findings are chondrocalcinosis. This is CPPD deposition in the articular and fibrocartilage. Also areas of calcification elsewhere of the skeletal system, known as a metastatic calcification. Extraosseous manifestations, most common is the renal stone, detected easily by a USG. Thank you.